Hi there. This lecture is about serous body fluids. In front of you on the screen, I have the competencies for this unit. So in this unit, we're going to talk about the terms associated with serous body fluids. We're going to define them and compare or correlate the serous fluids to the body source that they come from. We're going to talk about effusions and why effusions can occur, and we're going to describe body fluid collection, processing, and the risks involved during the collection procedure. We'll also talk about the appropriate tests for the fluid being analyzed and correlate the results with patient diagnosis and treatment. We'll talk about the difference between transudates and exudates and how we can tell them apart using laboratory results, and we'll describe the appearance of normal and abnormal body fluids. We'll talk a little bit about the cells seen in body fluids, and you have a separate slideshow for the practical that's in this module. And then we'll interpret results in the analysis of various body fluids. So let's talk about serous body fluids. When we talk about serous fluid, serous is a word derived from the word serum. So it's a small amount of fluid that lies between the membranes of the body cavities and those covering the organs. The membranes that cover the organs are called visceral membranes or visceral cavities, and then the membranes lining the body cavities themselves are called parietal. So these fluids provide lubrication, nutrients, and remove waste. So the three main body cavities we talk about are the pericardial or the heart cavity, the pleural cavity or around the lungs, and the peritoneal or the abdominal cavity. When we talk about these membranes, we talk about the lining cells, and they're called mesothelial cells. The only place you see mesothelial cells are in the serous or in the body fluid cavities. Okay, so just like ependymal cells are only seen in the cerebral spinal fluid, they're the lining cells. These mesothelial cells are only seen in the body cavities. So again, the parietal mesothelial cells line the cavity wall, and the visceral mesothelial cells cover the organs contained. And then the fluid fills the space in between the two sets of membranes. So serous fluid is different from spinal fluid because serous fluid is an ultrafiltrate of the plasma. So it's actually derived from the plasma. So again, like I said, the word serous comes from the word serum, related to plasma. So it closely resembles plasma. It's not a whole separate fluid as spinal fluid is. So you can see on this table below, normal appearance is pale yellow and clear. And depending on the appearance, could be a various source of other issues. So for instance, if it's white or turbid, there's probably WBCs or infection. And you can have WBCs there for other reasons besides infection, and we'll go into that later. If it's bloody, of course it's possible that there's RBCs or maybe a hemorrhage within the body fluid cavity or the body cavity. And if it's milky, it may contain chyle, which is lymph fluid and emulsified fats. When we talk about viscous or viscosity, that's how thick the liquid is. So something, an example of something that's viscous is like a yogurt or a liquid that's really thick. So reasons that serous fluids could be viscous or not like plasma, thicker than plasma, is because of increased hyaluronic acid or maybe a malignant mesothelioma or cancer of the mesothelial lining cells. Okay, so serous fluid then changes in pressure in the capillaries lining the membranes, and we talked about that a little bit back when we talked about how in hematology, by hydrostatic and oncotic pressure, or just the protein pressure itself, is what produces the serous fluid. So it's produced in the parietal membrane and it's reabsorbed in the visceral membrane, and that's done at a constant rate. So things that can affect the production and reabsorption of those fluids are changes in the osmotic pressure and the hydrostatic pressure. So remember, the osmotic pressure is due to the dissolved solutes within the plasma. The hydrostatic pressure is the pressure in the capillary tubes. And then also the concentration of whatever chemical components are in the plasma. So hydrogen, potassium, proteins. And then also production and reabsorption are influenced by the permeability of the blood vessels and the membranes. So if they allow more stuff to go through, it may reabsorb at a different rate or produce at a different rate. So usually those are in balance, production and reabsorption, and we'll talk about what happens when they're not in balance. So changes in pressure within the blood, concentration of the chemical constituents or ions and chemicals in the blood, and the permeability of the blood vessels and the membranes are all three things that influence the serous fluid production and reabsorption. So just like there's three main body cavities, there's three main types of serous fluid, and they are defined by the body cavity from which they come. So pericardial fluid is from around the heart, pleural fluid or thoracic fluid is from around the lungs, and peritoneal or acidic fluid is from the abdominal cavity. Reasons we may analyze these fluids, maybe someone has an infection, there's a hemorrhage, they have a malignancy, they have other disorders. So for instance, someone who can't breathe very well and they are found that they have fluid around the lungs, we may look at that fluid. Or someone who's maybe in liver problems like cirrhosis or hepatitis may have a really distended stomach and they find out that it's full of acidic fluid. So they may want to analyze that also. Just like the fluid is named from the cavity, the procedure to collect the fluid is named for the cavity also. So the collection is always done by needle aspiration, paracentesis around the stomach organs or in the visceral cavity, the abdominal cavity. Thoracentesis is around the lungs, and pericardial centesis is from around the heart. So basically they stick a really long needle into whatever body cavity is and they withdraw fluid. They could withdraw a half a cup of fluid, they could withdraw liters of fluid. It just depends on how much they get out of there, and then your sample will be a part of that. When they talk about lavage, it's when they actually kind of flush the cavity with Ringer's lactate or saline, and then they pull it back out for analysis. So they're trying to flush and see if there's any cells or what else is in there. When we talk about effusions, an effusion is an increase in the serous fluid because there's something wrong with the production and reabsorption process. So like I talked about the liver, someone with a real distended abdomen may have an issue with their liver. The production exceeds the reabsorption, and so the fluid builds up in the cavity. So effusion is a general category of excess body fluids in a cavity. Part of our job is to analyze that effusion and tell the physician the lab results that may determine if it's a transudate or an exudate. So it's important you understand those terms. A transudate is due to a systemic disorder. So it disrupts that balance between production and reabsorption. For instance, a disease such as congestive heart failure, nephrotic syndrome, or metastatic cancer. Heart failure may cause excess fluid to be around the lungs. A nephrotic syndrome or an issue with the kidneys may cause excess fluid to be around the heart, and so might cancer. So the transudate then is a type of effusion that's a result of a systemic disorder, so a system-wide disorder. An exudate is usually an effusion that's a problem with the membrane themselves. So it's specific to that membrane that involves that direct cavity. So it's usually thought of as an inflammatory process. It can be due to an infection, inflammation, or a malignancy. For example, a pneumonia may cause a pleural exudate. They may cause fluid to build up around the lungs. So might trauma. Around the heart, if someone has a heart issue that involves an infection, the membranes may become inflamed, and then they can't produce and reabsorb fluids like they should. So you need to take this table and compare it to your book. Your book does not have any of the less than or greater than signs. So you need to take this table and go in and fill in the table in your book, and that table is on page 204. It's important that you understand the difference between a transudate and an exudate. Transudates are almost always pale yellow and clear. They pretty much are equal to serum. They have a low specific gravity, under 1.015. They have a low protein. They usually don't have fibrinogen or spontaneous clotting. The amylase is low. The LDH is low. The cell counts are low. So everything's lower on a transudate. On an exudate, then, it could be any abnormal color. So remember, the transudates are just due to like a chronic condition like congestive heart failure. An exudate is due to a problem with the cells or the lining of the membranes themselves. So an infection or whatever, a malignancy. So any abnormal color, there could be blood present, it could be cloudy, it could look pussy. It usually has a high specific gravity over 1.015, and then the glucose is significantly less than the serum level. The protein is higher. The fibrinogen, it's possible that there's fibrinogen there, so that sample may be clotted when you get it. The fluid to serum amylase ratio, so they do an amylase on the fluid and an amylase on the serum. The ratio is almost 2 to 1, so it's almost 2 times greater in fluid than it is in serum. The bilirubin is also usually 0.6, of a ratio 0.6 or greater to the serum bilirubin. The lactate dehydrogenase is usually more than 60% of that of serum, and the cell counts are usually high, greater than 1,000. So understand the difference between transudate and exudate. So sample collection and handling, when the physician's getting the fluid collection, so whether it's a pericardial centesis or a pleural centesis or a thoracentesis or a abdominal collection, sometimes they forget to get the EDTA tube. That tube has to be collected right away. So what they'll do is they'll get the fluid in a big bag, and if they forget to get some fluid in the cell count and differential, you may have to get it out of the bag and it may be clotted. So one of the things you can do as a lab tech is help set up a system so that the EDTA tube is right on top of that collection kit, so that they don't forget to get it. Sometimes physicians and nurses don't understand that you have to have that EDTA tube for cell count and differential. You'll use a heparin tube for chemistry, serology, microbiology, and cytology. And usually you get a large amount of fluid because they don't just go into those body cavities for no reason. There's not a lot of fluid in those body cavities typically, like we learned in the introduction to body fluids. And if there's an infusion, sometimes there can be huge amount of fluid. So we also want to get a blood specimen at the same time so that we can compare results. People's lab tests can change from day to day, so we want to get the sample that's collected at the same time as the body fluid in order to compare the results and give the ratios to the doctor. So again, like the table, you can see the tests listed here. These are all done on almost every body fluid that's collected, or I'm sorry, serous fluid that's collected. They very rarely do serology on these because they can do those off the blood testing, and they do cytology pathology if malignancy is suspected. So the first thing we'll look at it is for a gross examination for color and clarity. We never use the word xanthochromic with a body fluid because that's reserved for spinal fluids only. We do our cell count the same way as for spinal fluid. You may have to dilute these. Sometimes the white counts are pretty high, and you'll have to count reds and whites separately. And then we'll do differentials. So you may see any cell that you can see in the peripheral blood. You may see mesothelial cells, and you may see malignant cells. So here's an example of a mesothelial cell. This particular person, actually this cell right here is a multiple myeloma cell. That's I think a mesothelial cell, and these are white blood cells. This person right here has multiple myeloma, which is a disease of the bone marrow. These are all plasma cells. You can tell they have the nucleus is off to one side. They have a slight halo. Mesothelial cells then are unique to serous fluids. They originate from the lining of the cell or the body cavities. So here's another plasma cell. These are mesothelial cells. So there's a mix in here. They're a large round cell, very round, lots of cytoplasm, and the nucleus may be off to one side. They kind of look like a fried egg appearance. They're single or they may be in sheets, and the nucleus takes up about a third to a half of the cell. And you may see nucleoli also. Okay, so here's some more mesothelial cells. These are in sheets. They may appear in clusters. You don't, for these purposes, don't have to worry about, for my purposes, if they're reactive or not. But you do have to know that they'll appear to have like window pane separators. So they'll look like window panes, cell windows, and those are mesothelial cells. Otherwise, malignant cells are a solid cluster of cells. So this one happens to be a macrophage with Candida species and a pleural fluid, and then with mesothelial cells. So this person actually has Candida yeast infection in their pleural fluid space. If a person has malignant cancer or a cancer that's metastasized, there's a significant chance you may see malignant cells in serous fluid. They're usually really, really blue. They may be balled up as clusters of cells. They may have vacuoles in them. But a lot of times if there's an organ cancer that's starting to metastasize, you will see these cells. So they're more irregular shaped nucleoli. They kind of have uneven distribution. They're more irregular shaped. And we would always send these to cytology. Even if you have cells that you think are maybe mesothelial cells, you would still send them to cytology because you're not qualified to give the final call on those. So here's an example of malignant cells. There's a mesothelial cell. These are big, nasty malignant cells, and there's huge vacuoles in them. And that's from a peritoneal fluid, so that's from an abdominal cavity. You can see how big these cells are in relation to the white blood cells. Here's another example of a lady with breast cancer, 42 years old, I guess. But you can see these cells are irregular shaped. They don't look like mesothelial cells, and they're quite large. Here's an acidic or abdominal fluid, someone with GI bleed. So GI bleeds, as we know, can be due to colon cancer. So this person has cancer cells in their abdominal or acidic fluid. So they did a lavage and got these cells out, and they're big, they're vacuolated, they're irregular, and compared to a white cell, they're huge. Here's a 30-year-old with back pain. This is a pleural fluid. This is found, they also had a malignant tumor on the spinal cord, and so they had this effusion, they had these big malignant cells in there. Okay, in patients with systemic lupus, which is a autoimmune disorder, where the patient's own antibody attacks the patient's own organs and body system. So an LE cell is a neutrophil that has engulfed a mass of nuclear material. So this is an example of an LE cell. These are actually the lobes of the nuclei of the neutrophil. You can't really see the outline of the neutrophil because this whole bit of nuclear material has taken up the whole space of the cell. But an LE cell then you see in lupus. Okay, so we're going to talk a little bit about chemistries. And I'm going to pause this just for a second. I'll be right back. Okay, I'm going to pause here and I'm going to put this in another part of this lecture. So we're going to end part one. This is going to be part two. We'll pick up with chemistry.